Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Salam Namo Buddhaya. May peace be upon us all. Good morning, ladies and gentlemen, and welcome we say to all offline and online in the Charles Darwin University LED simulation activity. Poltekkes Kemenkes Denpasar at the Midwifery Departmental. Poltekkes Kemenkes Denpasar with our turn today. LED simulation normal labor and solder dystocia midwifery department of Poltekkes Kemenkes Denpasar, Poltekkes Kartini Bali, and Charles Darwin University Australia, Denpasar, Bali, on Wednesday, June 26, 2024. The Honorable Director of Poltekkes Kemenkes Denpasar, whom we respect, Deputy Director at the Poltekkes Kemenkes Denpasar, Head of Academic Administration Subdivision and Head of General Administration Subdivision Poltekkes Kemenkes Denpasar, Head of the Midwifery Department Poltekkes Kemenkes Denpasar, We also respect the lecturer and student of Charles Darwin University, Poltekkes Kartini Bali, moderators, facilitator, research team, and staff of the midwifery department as well as fellow midwifery department students who we are proud of. We offer thanks to God Almighty because with God blessing we can all gather here offline and online in the LED simulation event of Midwifery Department Poltekkes Kemenkes Denpasar. Let me introduce myself, Putri Citra, as a master ceremony who will guide today's event from start to finish. Distinguished guests, before the event begins, allow me to read the series of events for today. The first opening, prayer, speech from Director of Poltekkes Kemenkes Denpasar, representative Poltekkes Kartini Bali, and representative from Charles Darwin University. Reading moderator CV, normal labor simulation session by Poltekkes Kemenkes Denpasar and Poltekkes Kartini Bali. Normal labor simulation session by Charles Darwin University. Discussion session. Break. Shoulder dystocia simulation session by Poltekkes Kemenkes Denpasar and Poltekkes Kartini Bali. Shoulder dystocia simulation session by Charles Darwin University. Discussion group. Submission of certificate. Group photo session, and the last is closing. The attendance, before we start today's event, let's pray together to our respective religious belief. The attendance, please to stand. Pray begin. Pray finish. To all attendants, please sit back. The next event is speech from the Director of Poltekkes Kemenkes Denpasar to Mrs. Dr. Sri Rahayu as Stars MKes, or those respecting the time and place are welcome.
Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Shalom, namo budaya, salam kebajikan, salam sehat untuk kita semua. Good morning, ladies and gentlemen. For the first, let's thanks to the God because with blessing we can together here in this activity LED simulation. Normal labor and shoulder dystocia midwifery department of Poltekkes Kemenkes Denpasar. Whom we respect, Head Department of Midwifery, Ibu Somoyani, lecturer from Charles Darwin University, Isita and Mpo, good morning. All of facilitator and lecturer from Poltekkes Kartini Bali, good morning. All of students from CDU, Poltekkes Denpasar, dan Poltekkes Kartini. Good morning for all. For the first, we would like to express my gratitude to all the committee who have prepared this activity very well. Thank you very much. And we apologize because the director could not present with us. Because he was in Semarang to follow a course for 2 weeks. So she cannot here today. One of the goals of Poltekkes Denpasar is to produce quality and globally competitive graduates. To produce graduates who can compete globally, of course, the activities international standard is important. So the joint simulation activity between CDU, Poltekkes Denpasar, Kartini, Bali will certainly have a lot of competencies. Not only related to writing competence, but also English skill maybe. You can all improve both. This simulation will give us all an idea of how to handle normal labor, soldier dyslexia, cases in Indonesia and Australia. So, through this simulation, student and supervisor can exchange various information experience in handling childbirth, especially those who experience in soldier dyslexia. I think that's all I can say. Congratulations on participating in LAB simulation. Hopefully, all participants can follow in this activity until the end. And I hope this activity is useful for all of us. Apologies if there is something don't like. Finally, I close with Haram Santi. Om Santi, Santi, Santi. Thank you very much.
Thank you to the Director of Poltekkes Denpasar or your representative for giving your speech and inspiring word. This next event is speech. Representative for Poltekkes Kartini Bali. The time and place are welcome. Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Shalom Namo Buddhaya. Good morning, everyone. I'm the Honorable the Director of Polytechnic Kesehatan Kemenkes Denpasar, or the representatives, the vice, or the first vice director of the Poltekkes Kemenkes Denpasar, and all of the officials, the teachers, the researchers teams from both schools, the Polytechnic Kemenkes Denpasar and Polytechnic Kesehatan Kartini Bali, and for all the students that come here from the Poltekkes Kemenkes Denpasar and Poltekkes Kartini Bali, and also the students and the facilitators and teachers from the Charles Darwin University Australia, welcome. And I'm Chania, and from the Polytechnic Kesehatan Kartini Bali, would like to say thank you very much, and then we are very grateful to have this chance to share knowledge with all of you from both schools from Bali and then from the Charles Darwin University, and then we hope that we can. And also, I want to say apologize and send greetings to all of the participants for today that our director is not available for today. And then we have our representative here, Ibu Noviani and Ibu Yuni, and also all the researchers from Poltekkes Kartini Bali. And we hope that the activity for today can run smoothly for the students. Take all the knowledge that you can get, and then you can share all the knowledge today, and you can ask what the other country usually does in their management of normal labor and shoulder dystocia. And then that's all. Good luck and have fun for today. And I would like to close. Om Santi, Santi, Santi Om. Wassalamualaikum warahmatullahi wabarakatuh. Salam sejahtera. Thank you, the representative from Poltekkes Kartini Bali for giving your speech and inspiring word. The next event, it is an honor for us to welcome representatives from Charles Darwin University who will share their perspective and insight regarding midwifery. The time and place are yours.
Selamat pagi. Good morning, everyone. My name is Poltekkes. I'm a representative from Charles Darwin University. To the director, Honorable for Poltekkes Denpasar, I know she's not here with us today, but I know that she's here with us in spirit because she told me when I came on Sunday. And to the head of school, midwifery, the director at Poltekkes Denpasar, the director at Polytechnic, Kartini, lecturers who I've worked with so many times, students from Polytechnic Denpasar, Polytechnic Kartini, and Charles Darwin University. It's an honor for us as Charles Darwin University to be here to learn with you. So we really feel appreciative that you've opened, especially Polytechnic Denpasar, this beautiful place. And we're so grateful to be here. And I know I'll now speak to the students because I've said my thank yous. I know how you are feeling right here in this moment. I know you are feeling anxious. I am feeling anxious as well doing this, but it's a normal feeling. But what I want you to realize is we are here to share knowledge. We are here to share different practice. It's all about sharing knowledge because I believe strongly that as we in this time, in this moment, we should be able to understand how midwifery works in that global context. And our sharing knowledge is going to enhance or maybe improve the way that we provide care for mothers and babies and families that we care for. And as you do this today, remember, it's not about perfection. There's nothing perfect in the world, but it's all about applying yourself in this moment and doing the best that you can to be able to share the knowledge with each other. I'll say this openly. This is one of the moments that I've always been waiting for because it fills my heart when I see future midwives in one room sharing knowledge. So I'm hoping that today you remember you're pushing yourself out of the comfort zone. And this is a great moment for you. So thank you for this opportunity. And maybe I'll say just one thing before I go and sit down. There will be a little bit of research that we do because as the three schools, we're really always thinking about ways that are going to help you learn more. So this activity here today is really about trying to see if you share by doing, is it going to help us all as midwives and as students to share knowledge and leave this place with so much knowledge and so much information about how we do midwifery. So thank you very much. Don't stress. Take a nice deep breath. Believe in yourself. Students, can you do one thing for me? Can you say, I can do this? Say it with conviction. I can do this. I can do this. Thank you. We believe in you. Believe in yourself. You can do this. Thank you very much.
Thank you to the representative of Charles Darwin University for your giving your speech and inspiring role. Distinguished guests, this LED simulation activity will present a very interesting practical simulation regarding normal childbirth and shoulder dystocia which will be moderated by Mrs. Niputugita Anani SRK in my midwifery department. Before that, allow me to explain the CV of Mrs. Niputugita Anani SRK. Niputugita Anani SRK. She is a midwifery lecturer of Poltekkes Kemenkes Denpasar. She is graduate from Professional Study Program Poltekkes Kemenkes Denpasar. That is a brief explanation CV of our moderators. The next event will be hosted by moderator to Mrs. Gita Anandi SRK. Are welcome.
Good morning. Thank you for the Master of Ceremony for the time given to me. Good morning to all honorable attendees. Welcome to Midwifery Department of Poltekkes Kemenkes Denpasar in the LED simulation of normal labor and shoulder dystocia. Midwifery Department, Midwifery student Poltekkes Kemenkes Denpasar, Poltekkes Kartini, Bali, and Charles Darwin University, Australia. On today, 26 June 2024. My name is Gita Armeni and I will be the moderator for today's event. Okay, first, before we begin the simulation, I will explain the rules of the simulation. First, this simulation will be divided into two sessions. The first session is normal level simulation and the second session is shoulder dystocia simulation. The second rules in the normal session, in the normal level simulation, every team, each team has 60 minutes to deliver the simulation, and in shoulder dystocia, every team has 30 minutes to deliver the simulation. The third, in this simulation, will carry out interns from Charles Darwin University first, and then followed by team from Poltekkes Denpasar and Poltekkes Kartini Bali. The last rules is discussion session will be held after every season, after both teams have finished the simulation. Okay, before after explaining the rules, we can come to our session, the first session. The first session in normal level simulation. The first team is from Charles Darwin University. You have 60 minutes to deliver the simulation in this normal level simulation. You can have prepared first. The facilitator from Charles Darwin University can accompany the students.
Duh, buka Emira.
Begin the simulation because the Charles Darwin University students still have to prepare first. We can take photo together first. So please, Deputy Director of Poltekkes Kemenkes Denpasar, Poltekkes Kartini Bali, and Poltekkes Denpasar to take place in program foto bersama.
Setiap hari di rumah. Kenapa?
Ready? Now we can begin the session.
Sekolah ada HP, Mam.
Wait, we're just trying to organize ourselves because we are in a different place. So we just wanted to make sure that everything that we have, we're going to make it work for us. So just to let you know that there'll be 4 of us each will be the facilitator. I'm the woman, and then we've got 2 teams of midwives. So you see us, because we've got 4 students, we kind of swap over. So that first students do first stage of labor, and then the other pair will do second stage onwards. So just to give that to you so that you're not confused as to how many people are in the room. So over to you, Eve.
So I'm going to start narrating the case that we have built up. So we are 8:30 in the morning of the 24th of the 6th, 2024. We have Ibu Made here, who is 25 years old. She's married to Bayan. Both Ibu Made and Bayan are teachers, and they live with Bayan's parents. Ibu Made is G1, P0, A0. Her last menstrual period was 10th of September 2023, and she has a regular 28-day cycle. Ibu Made was not using any contraception when she felt pregnant. Ibu has presented to your labor room, accompanied by her family. She reports that she has been experiencing contractions since 3 o'clock this morning, and Alana and Chloe are the midwives on the duty. Over to you, Bo. We're going to start with this meeting to please have some money to see on any record and all the presents. Just to make sure we've got but right here, if you want to come and take a seat. Okay. How are you feeling? So we might say started at 3 a.m. this morning and then 5 minutes of lunch.
Yes, they started at 3 and they had a little hot.
And your birth family is that you're interested in a natural birth and no pain medication.
No, I not rather do it without,
And how you handle it?
It's all right.
You can offer any massage you get back from your husband, you can help with that. Otherwise, just let us know what we need to do. Once you're through this interaction, it's going to take some observation of your blood pressure, your heart rate, and just check everything is really normal. I just wanted to check if you have any bleeding, no bleeding, one is bleeding, and postural membrane. Water and pressure broken, so you tap and the top is really hard. Your name and your date of birth, please. Thank you. Will they do to anything? No, excellent. Perfect. Just gonna go get the equipment. Vital signs. Temperature is absolutely normal, sitting at 36.8. Blood pressure for Ibu is sitting at 110 on 70 mmHg. Someone's just going to check your pulse and your breathing. Pulse is 80 and respiratory rate is 16 per minute. Ibu looks well and she's got no edema or no power. Do a measurement, see where baby is positioned. And if you want to, you can do this. Would you need to run a sample? This student might come to do this sort of extrude, so wait to the beginning of the end of the term. Midwife explains Ibu to go and pass urine before performing an abdominal examination and listening to the baby's heart rate. And alongside, we will also perform a urinalysis to check for any protein or glucose in the urine. Thank you. Urine analysis, please. Midwife Chloe is just examining the tummy, checking for any extra signs of edema or any marks on the tummy, alongside performing and determining where the baby is lying at the moment. On measurement, Ibu is measuring 39 centimeters, which aligns with her gestation at the moment. Her presentation is cephalic, and the baby is presenting 3/5 above the brim and is in ROA position. Baby's heart rate is measuring 124 beats per minute, and there are no decelerations heard and good variability.
It is very good to here, very in the right position. Keep doing what you're doing if you're happy with that. Do you need a hand off the bed? No, you're okay. Do you need a drink? No, you're okay.
It starts to feel a little bit more uncomfortable as the labor is progressive. It is now 9 o'clock and Ibu is contracting 3 in every 10 minutes, and the contractions are lasting about 45 seconds each. Both midwife Chloe and Alana are giving Ibu different options of positions that she can take up to help with her labor, hydrating her by offering her drinks of water and some lollies in between. Ibu is keen to try different positions, but continues to remain a little bit uncomfortable. As the time progresses, Ibu is wanting to know how far along her baby is.
And the vaginal examination just to check. I've been having these contractions for a long time.
The children sit on by, oh, of course, it's not a problem. Have you had a vaginal exam before?
Yeah, I know, like a week ago. Yeah, we were. Especially sweet.
Okay, yeah, it's very similar. So please have an examination. We just test for your cervix, how dilated it is, and how extent it is. And that will give us a good indication of how far along we are. Is that okay with you?
Yeah, I want to know. I want to know.
No, no problem. We'll get you to lay on the bed and do that. So whenever you're comfortable, whenever you're ready, we'll lay you down, okay?
Ibu is wanting to know her dilation, and midwife Chloe explains what a vaginal examination is and how it will be performed before going ahead and performing a vaginal examination.
Heart rate at 128.
Midwife Alana continues to check for baby's heart rate every 15 minutes, along with maternal pulse every 15 minutes.
Okay, we're gonna need you to put your knees up and your feet. We're gonna have to knock your knees out. Take the perfect position. Just gonna cover you with this sheet. If I'm comfortable at any time, this one is okay. Okay, just actually give you a back for me.
Midwife Chloe takes consent and performs a vaginal examination on Ibu. Ibu's cervix is centrally positioned, it's fully effaced, 6 centimeters dilated, membranes are intact, there's no caput, no molding, and the position is ROA, and the baby is sitting at station 0.
Okay, so it's all okay. So, the service is 6 centimeters dilated, which is wonderful. You get to 10 centimeters before you start cooking. Your cervix is really nice and thin, which is great. So you're making really good progress. Keep coming down into your pelvis. Keep doing what you're doing. Keep working and back into the wall. Okay? Yeah. The question. No, yeah, it's just one thing. Okay, we'll move around.
It's 9:30 now, and Ibu Made is coping well with her labor, and she's walking up and down and breathing well through each contraction.
Something helpful? Yes. Okay. So you find the massage, okay? Maybe it's doing great.
Both midwife Chloe and Alana continues to monitor baby and mum as per protocols and provide the holistic midwifery care by working with Ibu and her preferences of non-pharmacological pain relief. Ibu's contractions are now getting moderate and are lasting between 45 to 50 seconds. And she's contracting 4 in 10 minutes.
No, okay. We do have, if you need more contact forms.
Ibu is requesting something to help cope with her pain. However, she does not want any pharmacological pain relief options.
You got your pain relief, we can continue to do your massage, we can put your warm shower on the back panel, we can keep changing your position, bouncing on the floor, laying over the bed, we can attend to the and any of these options on the floor. You're okay, that's what I want to try and figure out some way. Really well.
Midwife Chloe and Alana continue to give Ibu different pain relief options that are available as per Ibu's birth plan. And while they're providing the care, we have a shift changeover and new midwives, Ash and midwife Adelaide, will be taking over the care for Ibu.
So this is she has been with us this morning. She started I think at 3 a.m. 5 minutes apart. All observations are within normal limits. Normal pregnancy, no bleeding, membrane intact. She's fully effaced, 6 centimeters dilated, and sexually severe. ROH. Send the GP studies. Negative. Yeah, and look. Was it? Her husband, you are, he's been helping with massages and her breathing. And very well coverage and getting through each contraction. Thank you so much. Lovely to meet you. We're just going to go now. Adelaide and Ash. Thank you so much. My name's I'm just going well, 4 centimeters to go. Do you know what the injection is? So when we do a video, we injection
Midwife Ash is utilizing the time before the baby's born and asking about third stage management and getting a consent for oxytocin.
So just want to get a little on that, so I'll just leave the room.
Ibu is experiencing spontaneous rupture of membrane, and the midwives observe copious amounts of clear liquor. As the waters break, Ibu reports a strong urge to push. Midwife Ash has a look and she observes a head-on view. Maternal and fetal positions remain within normal limits. Ash is asking Ibu to keep breathing through the contractions, and we in Australia encourage the women to remain in the same position or any position that they would like to be in, be in all fours or assist delivery with the help of gravity. But for the purpose of this demonstration, we will be demonstrating the delivery on the bed with the use of the dummy.
Warm compresses.
Midwife Ash is applying some warm compress on the perineum to assist with the delivery of the baby and provide some stretching to the perineum.
Position.
Great, two, head forward, head on, and forward.
Get delivered. Yeah. A live baby girl is born spontaneously and via vigorous crying. The baby is put on skin to skin.
Well done.
The placenta is still in situ.
Alright. The next thing I'm going to do is just count that at 1 minute. So run through possible appearance, what have I seen?
You're seeing a good vigorous crying for the baby, good tone,
Good, okay, cool. So I've got appearance 1, I've got pulse within the limits, so I've got a 2, grimace, I've got a 2, activity, I've got a 2, and respiration, I've got a 2, so we're at 9. Something was structurally like now, it's gonna be that person which is gonna help you in the organization. Oxytocin, attendance firms, one. Perfect. Now I want to here, I'm gonna
Oxytocin has been delivered for third stage management, but the cord is still pulsating, so we are not clamping until the cord stops pulsating.
I'm gonna get the plants prepared. Freeze plants here. So we use this time with card breastfeeding as well, and obviously maintain it's stop pulsing.
As the cord stops pulsating, the midwives clamp and ask Bion if he would be interested to cut the cord.
There, husband cuts our cords.
Midwife Adelaide continues to provide care for the newborn, while midwife Ash is looking after mum and making sure that she's not excessively bleeding.
So we're at the 5-minute stage again. This one is going to stay in that part.
Baby is nice and pink, and has been vigorously crying and actually breastfeeding.
Good. So we've had improvement from our parents. I help you with this. We've had about 20 minutes before, and we've got separation bleed. So we're to do
We wait for the separation bleed. Once we see a separation bleed from the uterus, we assist with the delivery of the placenta by tucking the uterus back. Placenta is delivered and gets assessed by midwife Adelaide for its completeness, and the membranes appear to be intact, appear to be complete.
So obviously, as we just mentioned, just to make sure membranes are intact, making sure the cord and structural integrity is not intact, which I'm happy with. One thing that we did offer is whether we want to do it in front of the mother, whether she liked that, or whether we do it away. Would you like me to assess the placenta in front of you? You're aware of that? Yeah, no worries. And would you like to take it home, or what would your plans with it? Yes, no worries. That's it. So if you're going to survey to change your make sure the separates it's going to that all gets too clean, you might just take this
Midwife Ash is now just determining if there's any tears or that requires suturing for either.
Everything's intact, great. Yeah, I think the next thing that I wanted to do, I know you're breastfeeding, so it's just going to do some measurements. Okay, so just do a head circumference, measure the length, and measure the weight. Also, a good time for us to discuss whether you would like to look at a lubricating injection, have a negative injection. We discuss if you have any information around those, would you like any education or something that's raised for you to take the consent?
Yeah, it's I told the neighbors that I'm happy for my baby to have provided me care.
Okay, perfect. That's also something we can do. You guys measure the loss. No worries. Now we
115 mils.
that's beautiful. And then just going to take the baby out. Okay, would you like your husband to come with me? Yes, my arm's going to come with me. I'm just going to measure a couple of things out.
Midwife Adelaide has just asked if she's able to do a head-to-toe check of the baby, measure the baby's head circumference,
determine the weight and length of the baby and has also asked Ibu for consent for hepatitis B and vitamin K injections. Ibu's consented for that, and this only occurs after 1 hour of uninterrupted skin-to-skin and first breastfeed.
So I'm going to do a check of blood, then check fundings, check blood loads, do symptoms.
Midwife Ash is performing a postnatal check on Ibu.
So we're going to take
3 fingers to low.
right?
Baby's weight is 3,000 grams and has a head circumference of 36 centimeters and a length of 48 centimeters. After a full round of postnatal check and vital obs, Ibu is offered lunch. She's offered to use the shower and empty her bladder.
Beautiful. I can run through the numbers and stuff. Actually, 3,000 grams.
Ibu's postnatal obs are well within normal limits, and so are babies. Midwife Adelaide returns Ibu's baby's daughter to her for full breastfeeding. And sing.
Charles Darwin University team. And now we can continue from the for the simulation from Poltekkes, Denpasar, and Poltekkes Kartini Bali team. The team can prepare first. The both team finish the simulation. Denpasar and Poltekkes Kartini Bali already. Now we come to the session. You have 60 minutes to deliver the simulation.
Hey everyone, thank you for the time. I'm Pika as a narrator. Now we will simulate the normal labor. First, in our team, there is Dina, Dian, Putri and Amalia as a midwife, Monica as a husband, and Juwita as a wife. On 14th of May 2024, at 8 AM, Mrs. Made came to midwifery private clinic because she has been feeling contraction since 3 AM.
Morning, please. Morning, mom and sir. I'm Lina, and this is my friend, Mrs. Jan. I'm talking with the online annual please. Made. So, sir, what can I do for you? And this is okay, now I'm having I think I am not going to stay because I think feeling contraction is my mistake. Okay, you already feeling the contraction, yeah? So now I will check your frequency sign for the first one. So yeah, could you please check if the Mrs. Medical sign? And sir, could you bring the medical pregnancy book? So, sir and Mrs. Made, based on the medical pregnancy book, now Mrs. Made is 25 years old with the first pregnancy, yeah, and it's the last menstrual period is the 10th September 2023, with the due date is 20 May 2024. And because for now, the pregnancy already term, and also Mrs. Made already feels the contraction, we need to check the normal of 2000 for the first one. It will be the normally, we can do examination for this month. Is that okay, sir? So first, the Made already get the people very from here. So they get the fix. Normal, yeah?
The results show that the blood pressure 110/70, pulse 80 times per minute, body temperature 36.8 degrees Celsius.
I will check your
children, the contraction also the final product is a offset. Maybe for now, you can go to the record. The table limit and here. We have common things for use. And the toilet is for gas and your husband will have to okay.
Recording.
And you can do the record the minutes. You already finished one? Following will be an yeah. So because we will do the information, please stay on the get. Okay, for the first how they did about the content. Yeah.
The results show that Mrs. Madi has progress presentation with station 2, uterine contraction 3 times in 10 minutes. Its contraction lasting 18 seconds and fetal heart rate 124 times per minute. Mrs. Madi urinated around 200 milliliters before the internal examination. The vaginal result is cervix dilated 3 centimeters, no knowledge, and amniotic membranes intact. Based on the data at 8, midwife made a diagnosis. Primigravida, full term pregnancy, birth in latent phase, live baby with normal fetal heart rate, cervical dilation 3 centimeters, 3 contraction in 10 minutes, and contraction duration less than 20 seconds.
In front of the contraction, which is something I will have the examination. There's some income from your finances.
Right now, Mrs. Madi reported that her contraction was stronger and more painful. Midwife do the second inspection.
I will do examination for you again because I think that with your vagina and maybe there is something uncomfortable for you like the first one, but you just let the relax, yeah? I will do the same like the so don't be nervous, yeah?
For contracted occur in 10 minutes, duration between 20 to 40 seconds, total contract 134 times per minute. Head descent station 0, cervical opening 5 centimeters, no infiltration of the fetal head and membranes. Amniotic fluid is still intact. Her blood pressure is 120/70, pulse 88 times per minute, temperature 37 degrees Celsius, and she urinated around 100 milliliters before the examination was carried out.
So congratulations, Made. Now you have an active test of blood pressure. So together with the 5 centimeters and from now I will have a break also with the and the clock 30 minutes and the body hours temperature 8 hours. And also for now, sir, the active test of the labor, you will get the strong contractions. And for that, I will give you the strong method to relieve your pain. And also here, you will help to Mrs. Made to get the pain about, yeah? And also, sir, I will teach you how to do get the pain after massage, so it will be reduced the pain of Mrs. Made. That's okay for you, Mrs. Made? That will help prepare the materials.
The observation result from 12:30 until 2:30 documented by midwife in Patosam.
We do in here. Okay, this is the birthing ball also. But on the side, we will do in sitting position. So please help your husband to sit on the birthing ball. Okay. Okay, here. Please take your position. You just need to relax and then please sit your foot on the ground about shoulder width apart. Okay. Okay, now you are on the right position. For the exercise, you can hold my hand. Here we will go to movement. For the first one, we will do the exercise from side to side like this. Just slowly, and then the part for the first we will do in 8 counts. You understand? This is the equation. Okay, keep the left and control the right. Okay. Okay, I will start from the 8 counts, starting from right. So what do you feel? Do you feel the contraction now? Okay, if the contraction comes, you can control inhale, exhale while doing the exercise. Okay, inhale. Oh, you did so great, Mrs. Made. Yeah. It is a great good job now. Just slowly. Okay, for the next one, we will do in circular motion. On the floor of 8 motion.
for the simpler like this. For the exmotion, we do it shape of it. So what you want to do, circular, circular, for the circular motion, we will go from the right side first, okay? Like this. And follow me, yes. Slowly, feel the contractions, taking out of the brain. Maybe for your husband, you can use the mom, baby switch, you can more relax. Yes, sir. No, I will give you the massage, but for now, you need to get the living position. So, yeah, and sir, did you help the Mrs. Madi to get the living position? The first one, you need to position like the table hands. And then you can drop your body in the ball, the half your hands. And then you can see in the left side on the back side. You need to relax, don't be nervous, just feeling the baby, will be the bone, with the relax, and don't be the nervous, just take a breath long, take a deep breath long, and you can exhale. And also, sir, you can massage Mrs. Made with these positions. You know how to do the massage, mister? Okay, let me help you. Stay in this position. In the Mrs. Madeli's position. First, you need to rub your hands until you get the warmth. You already get the warmth for your hand. And also you can use the palm, especially the upper of the palm. And you can do back at first massage when until the lower back in the back ones until the below of the foot. You can also the press if you don't prepare, so it will be not with the pain of the contraction. So you can do it together. It will be the relaxed form, Mrs. Madhu. That's right. How do you feel, Mrs. Madhu? Do you feel more relaxed? You can do the massage very gently, so Mrs. Madhu can feel it out. Yeah. And you, including something or you first from the person. Yeah, this is representing the breathing already. I will do the second one.
At 4, midwife perform an abdominal and internal examination. Result, fetal heart rate 130 times per minute, 5 contraction in 10 minutes, duration more than 45 seconds, head descent station 2, cervical dilation 10 centimeters, no knowledge, amniotic membrane rupture before examination at 3:45, and amniotic fluid is clear. Blood pressure 120/70, body temperature 37 degrees Celsius, and pulse 80 times per minute.
Okay, yeah, it's okay. So, sir and Ian, could you please move on the bed? And sir? Feeling comfortable in this posture? Okay. And sir, you can stay in the side of the Monday. We need to prepare first for the labor. You can prepare the masal or the food maybe to keep the nutrition and the energy, yeah? Because we still need to prepare for the labor. So don't be nervous, just take a bit long and you can take it to the plastic, yeah? So in this, if you want to push that for you need to follow our plan for now. You can follow okay. Just sit in the left side for now, yeah, Mrs. Magic?
So now you will know what to do. Okay, you need to follow our instruction. Okay, so now let's try together. So the configuration, you need to take long and deep breath. Please take long and deep breath. Yeah, if you want to push in, just exhale and then push hard your baby. Okay, let's do it. You feel the contraction, please push hard your baby and then look at the stomach. Okay. Okay, you feel the contraction. Then we try again. If you feel the contraction, just take a deep and long breath. Please push hard your baby. Okay. Okay, good job, Sam. Here, Lina will give instruction more, okay? If you go through the contraction or the contraction is not, you can take a rest. If you can give your wife the break, okay?
This is very good, Mrs. Made. This is very well and good. Just give the instructions, yeah? You need to relax. And see you're feeling contractile, you need to take a deep along, as the Mrs. Yang teaching you. So now, if you feel in the contraction, you can bend your leg and then you can push your hand in your foot and then also you can push your baby. And sir, you can see the Mrs. Made and then you still give your message and the information to be the good condition for mentally for Mrs. Made. Yeah? So, Mrs. Made, I will do and I will let you know if you're feeling the strong contraction. Tell me if you're feeling the strong contraction. Do you feeling strong contraction? Take a breath long, Mrs. Made. Yeah. Yeah. That's good, Mrs. Made. Take a breath long. Yeah. Yeah. One more time. Take a breath long. Push, push. Yeah. Okay.
Just take a short break, okay?
Wait a moment, Mrs. Made. Okay. Now, listen me. Just take a short break. Yeah. Don't be long one. Just take a short break. Yeah. Pull. One more time. That's good, Mrs. Made. That's good. That's good. That's good, Mrs. Made. That's good. Yeah.
At 4:30, a baby girl was born. The weight 3,000 grams and body length 48 centimeters. The baby cried spontaneously.
I will check the abdomen. There is no sex of baby. So here I will indicate the position to have you birth the placenta. Okay. Okay, now I will indicate the position.
Follow the baby. Yeah. So congratulations, not answer. Your baby girl finally born and cried up spontaneously. From now, I will help you and the baby to get the breastfeeding. And I'm not clean the hand because you will be wet off the baby because all the looking for the nipple. So now I will put your baby at the stomach. Straight up. Okay.
This will be fixed 1 hour long time to get the baby finally from it. I will give it for the placenta. So in this focus for the baby, officer, this focus with the mom, yeah. Just keep the impression, this can be the get the food or the some water maybe. It's very less than your placenta, yeah. Don't be the campus and just keep the going and then focus your baby, yeah.
Active management of the third stage was carried out and the placenta was buried for 5 minutes after the baby was born. No laceration occurred. Estimated blood loss is approximately around 150 milliliters.
Get to black, then open your here, if you happen to give birth of the placenta, okay? But that's it. So, Mr. Made, answer your baby and your placenta is born with a good condition. So now I will observe you about 2 hours to check your pulse, blood pressure, and also your baby and the Mr. Made before we need to move to the maternity room for hospital. So from now, I will take a rest for the sterile the vaccination and also, sir, you can still get a drink or something with the energy. And now I will help again to remember the unit mandate and don't be nervous. Maybe there is something wrong with your contractor or maybe you feel uncomfortable. We can just call you now, yeah? You need something maybe? Okay, no one now, yeah. Okay, just call him up. Maybe there is something. No, there is not that. So yeah, let's wait on this Monday.
The observation result on first stage have documented by midwife in photograph. That conclude our simulation. Thank you.
Thank you for the great simulation from team from Poltekkes Denpasar and Poltekkes Kartini Bali. As both team finally finished the simulation, now we came to the discussion session. As we can see from both simulation, there must be something similar, some similarity and some differences that we can see from both simulation that need to be discussed. So I invite anyone here, audience and also students who want to ask questions to both of the team, you can raise your hand. Do you have any question from the students and also from audience? Okay, I'll take the question first. From Poltekkes Denpasar and Poltekkes Kartini Bali team who wants to answer the question. If the head of the baby was born, are you usually directly cleaning the face of the baby? Want to answer the question?
So thank you us for asking about our group. Yeah, this is one of the rules of the hour labor. So the first one, if the head already going up, it means you need to clean the nose and the eyes of the baby. So we can see that sometimes the aliens of the part of the there. So it will be easy to see also with the placenta in the back ones. That's why we need to clean that to be cleared and then clean for the baby to get the safety whether nothing something wrong in there.
So maybe this is optional to do. If the face is clean, we don't need to clean the face.
But actually, we sometimes we use, but sometimes it's not too dirty for the baby because sometimes there's have the fluid in the body also with the head. We need to clean that.
Yeah, so the answer is conditionally based on the baby's condition. If the baby's condition is full of fluid, so we directly cleaning the face while we also check the cord in the neck. Okay. Do you understand? Yeah. Okay. So I invite anyone, if you still have any question, you can raise your hand. Okay.
Thank you, everyone. That was a very inspirational and insightful simulation for both sides, from CDU and from the Poltekkes, Kemenkes and Poltekkes Kartini. I want to ask about for the CDU students. I saw at the role play for the vaginal examination, you ask the woman if they want to do the vaginal examination. My question is because in Indonesia we do the vaginal examination every 4 hours, so that's the rule. How about if the woman in Australia refuse to do the vaginal examination? How do you know whether she is in full centimeters, full dilatation or not? Thank you.
Okay, there's a question for Charles Darwin University student or facilitator. If you want to answer the question now, from students or the facilitator maybe.
Yeah, so we do get a lot of people that will refuse a grant examination, assessing the whole picture. We can feel the contractions to see whether they're strong or mild. Perhaps she's just in early labour. If they're long and they're lasting long, you know that the cervix is doing the job, it's dilating the cervix. But externally, we can also see, you know, there might be, if she's in a position where we can see bulging or pouting of the anus, then we can see that also that's a great sign that she's dilated and not having to do that image. Any other? Yeah, and you're listening to her. If she's, you know, contracting, oh, you know, maybe it's not, oh, you know. So we're just observing and listening and working with the woman to figure out what's going on. Yeah. And a CTG, if she's got a CTG on, you can sometimes see that might indicate that she's getting close to the G. Yeah.
Okay, Ms. Shirley. The answer is sometimes in Australia, patient also refuse to do vaginal examination. We do the observation or check by other things like confection like that. Yeah, understand, Ms. Shirley? So okay, from both, if you have any question.
Thank you. Like you just said to both students for bringing it up, that was amazing to watch. Thank you. I don't have a question, but I think I just want to add to the VE space to say research is now coming up and starting to rethink the way that we provide labor care. Do we need to do VEs? Are they even important? That's a question that is coming up again now over and over in the research. You find that midwives who are really pro-physiological, pro-normal birth are starting to ask these questions. Should we be putting women through these interventions, or are there other things that we could do? I think the question is, if we think back really before childbirth was taken into the hospital setting, did our traditional midwives do VEs? I think that's what the question is all about. So that's why I find that now we're starting to rethink. We shouldn't be doing VEs when it's really necessary. But I know that, in our clinical practices, we're still working with the 4 hours of VEs sometimes. So it's just trying to rethink, do we really need to do them, or should we be doing them when it's necessary? Like Shelly was saying, we could use other signs. It's the whole picture. How is the woman behaving? What are the sounds? What am I seeing? So you're combining all those things. And if a woman declines or chooses not to have a vaginal examination, it's a choice. So we're always working in that space. So I thought I would just add that. Thank you.
Thank you as well. While we talk about the examination, I personally agree with my mindset that VE is really optional for the in case whether the case of the woman is allowed. And my other question is, do in Australia have pantograph and use the pantograph during labor?
It was up there.
That's all. Thank you.
Just to add on to the space of VE, vaginal examination. So that every woman who presents in labor in Bali gets a vaginal examination. Yeah, and you have to perform it every 4 hours. Yeah.
Okay, thank you. So I can summarize. Okay. I can summarize that in Australia, vaginal examination is optional, and in Indonesia, vaginal examination usually performed every 4 hours, and even before 4 hours if the woman already feeling some signs of want pushing like that. Okay, so we have to rating about that. We have to research about that because that's optional like that. Women have to choose whether they want to have the vaginal examination or not. Okay, we can go to the next question. Who wants to ask?
So once baby is born, you place baby on his tummy. Is that so? In Australia, we bring baby up to mum straight away up to the chest and do skin to skin, and you wash the babies before bringing it up to mum. Is there what's your the reasons why?
So the previous one, we put it out in this one. After that, we deal with the test. So we put in this, maybe there's something, yeah.
So actually, we clean at the stomach, but we doesn't clean for the hands because this will be guide of for looking for the nipple of the baby to get the breastfeeding. And after that, we put it in the, so maybe there's something for the baby.
Can you cover the whole there as well?
Okay, first of all, when the babies come out, we put the baby on the stomach because we not directly cut the cord. After we cut the cord, we put the baby on the chest to skin with the mom.
So we put it at the stomach.
And first, we clean it at the stomach, and then until the cord is not bleeding, or 2 minutes after it's coming out, we cut the cord.
So what is like you play with baby?
We clean the baby to keep the baby warm. Yes, from the amniotic, because the baby maybe in the normal labor we there in the room is not warm, so we need to warm the baby.
Like putting baby on in a blanket, putting feet.
I think sometimes it's
We put the blanket on the baby, so we keep the baby skin to skin with the mom, and we add the head.
Yeah.
for the stomach. Yeah. Because sometimes the baby has a lot of weight. It's like generally in the place there's already warm, but the baby get a lot of weight, so it would be so hard to find the nipple spot. The one it just next to it, it's not too like you get it's weight spot. That's why we just clean, but not holding for the cleaning, just a little bit. So started until the cutting the placenta. That's why we just keep it a little bit for the so the cleaning is not.
So the baby will not get the hypothermia.
Yeah.
How we try to make
Would you like tactile stimulation?
Yeah, I would simulate it in terms of that it all.
Yeah. It's not really good. Yeah, we don't change, it's just like a problem. Yeah.
Okay, so the answer is after baby born, the first they will get trained in the stomach and then positioning in the chest of the mother. And before they will get warm by the blanket and also using hand, but the hands not clean because it will help baby to move to find the nipple to directly early breastfeeding. Thank you. Another question? Yeah.
Thank you. So my question is, do you always check the protein body after the mom came to our facility? Because in this case, in your case, I understand the mom has a normal blood pressure and the normal condition. Thus, in Australia, you always check, do you do the check lab and protein body in the first and third semester of antenatal care?
You understand the question? Okay. We in Indonesia, usually when pregnant woman came to do antenatal care, we also we have to do laboratory tests like protein urine, blood, and also that in antenatal. So if the woman birth, we not check that again. Yeah, because they already had the result. So in Australia, every woman that came to birth also check the laboratory. Yes.
We check the urine just in case then age. So having something that's
Before you already check it now because it's already there. Oh.
And then they check it when they come into the hospital to give birth as well.
So it means every she get the hospital you need to check it, right?
Yeah.
Actually, maybe there's have the medical people like have the medical check. So maybe have the observation by the protein rate. You need to check one more time. So you check. Oh. Oh. Check all you do.
And if something shows
Oh.
If it's been labouring for a long time, it is simply just the
So I can summarize that in Australia, every woman that coming to the hospital to get birth, it must to have laboratory test, even if when they are pregnant in antenatal, they already have checked before. Okay, yeah. In Indonesia, also like that. In hospital, we sometimes do the laboratory test, but in midwifery practice clinic, we not usually do the laboratory test if there is no sign or indication about to do the laboratory test. Okay, Marco.
Sorry, I'm listening in that sense there could be a little bit of confusion between a urinalysis, and laboratory test. I think I'm sensing that. So if a woman is coming, definitely, that very first antenatal visit, they will get, the urine MCS, that's the laboratory test, because they're taking the urine and sending it to the lab. And then we might do that if we suspect that, there's any other thing during pregnancy, like you are suspecting a urinary tract infection, or you're suspecting preeclampsia, maybe sending that to the laboratory. But during pregnancy, it's the urinalysis that you can do at that point of care, whether deep stick or through a little machine. So I think I just wanted to clarify that there's, I think, two different ways of looking at it. When we are doing the urinalysis, we don't call it, like the laboratory per se, but we do it at the bedside or at the point of care where the woman is.
Oh.
I think that's clear, right? Okay. Okay. We can move to the next question. Question. Okay.
Thank you. My question is that, are there any, different positions that are recommended when, you deliver the baby in the second stage, or does the mom need to be on the bed? Can she be standing up and deliver the baby, all fours? Are there different positions, or just have to be on the bed?
Who wants to answer the question? In Indonesia, do every woman who give birth must be on the bed, or they have another position, another choice option, another option for position? Who wants to answer? Yes, the answer is in Indonesia, we also recommend some position for birthing women. They can choose their position. We also we first explain every position in the first stage, and they can choose the position that they want in the second stage. Because when they have the full dilatation, we ask first the woman, what position do you want to use, like that. In Indonesia, usually some birthing women choose to have the half sitting position like that in the bed. But also some women also use position like they usually like that. Yeah, some position also use. We can move to another question. Who wants any question? Okay.
Do you ask for consent before doing it with the woman? I'm not sure which ask if it's okay, or do you just do? Do you ask for consent when doing procedures? So we're taking your blood pressure, temperature, before doing your general examination. Say this is okay if we do this. Yeah. Same.
Yeah. Like communication from the patient, and I think the person will be saying, okay,
yeah. But I can say
yeah.
So just after mum goes to the center and you wipe everything down, how long after birth does that happen? So when the person already gone? Yes, and then I noticed that you like wiped it like up and down.
Just 50 seconds, 50 seconds. If it's for the clinic or the doctor's one?
No, the clinic. So after the mother has the third stage, the mother's delivered the center.
Oh, yeah.
I noticed that you wiped everything down.
Immediately after all is done. Yeah.
And you pop the pad on and the underwear like this straight after.
Yeah.
Okay.
If the condition is good, there is no laceration and all is done. So we need to immediately keep the mouth clean.
Do you use things like cold compresses on the perineal vagina after birth? Like, would you put like a cold pack?
No, not really. It's like a choice. Sometimes we do that, sometimes that.
Yeah, but you offer that to the
Yeah.
Okay.
Because actually asking for the mom things needed. Maybe if the cycling still the strong contraction, maybe sometimes we use, but not every month get that. Okay. This get it just important.
Okay, I think that's clear. We can move to another question. Okay. Sorry.
So when the scenario commenced, and the woman presents to the midwives, what we saw was, the questions were getting asked to the husband, instead of the woman. So when the woman presents in labor, do you usually, ask questions to the woman or just go by what the husband is saying. Both of them. But if in a scenario, husband agrees to something and the woman's like, no, what do you do?
Okay, I think that's clear. Any question? You first.
I want to know about the full conference on the so much of mom after all birth. So in Australia, this is always usually to do.
There's on the period. As baby is coming out.
The swelling of the joint.
It would be stop for the blood from the vagina or something. Smelling and fever.
Swelling is. Not directly, it's the skin, it's
Oh, I'm expecting one. It's like the menstrual.
You got to
Oh, it's not also one or you can get it one. More bigger ones, yes. Yeah.
Okay, that's enough. Okay, we can move to the next question if there is still any question.
You guys put glasses on, glasses, apron, guns. Is that from COVID or did you do that before COVID? It's to protect yourself.
Yeah.
From splash. We lucky to put it.
Yeah, but sometimes maybe it's very fast.
Yeah.
And we don't have the time to prepare. Yeah, I think the more important is the apron and the. Yeah. The gloves. Yeah, all the time. After COVID, we still use masks in the hospital. That's why the hospital today we use the mask.
Yeah.
Okay, that's clear. And move to the next question. Yeah. Mentioning.
I'm interested about the position. So in the scenario when the women in Australia encourage the woman to choose the position. In the scenario, we see that the woman choose the when the woman is all force position and the water is weak and she is full dilatation. She is still, if she choose to get a labor in the all force, it's okay. In my question is, how about the water is weak, she is in all force position, but the dilatation is not full. How about that? Is she still in all force position or?
You might encourage a different position, but if she's happy and comfortable there, that's perfect.
That's maybe that's the different in Indonesia. In Indonesia, if the water is weak
and she is not fully tolerated, she will move to the bed. Yeah, because to decline the cost of the water a lot.
To monitor it or monitor the lack of. Yeah.
Yeah, it's like observation. Yes, observation. That's why we need to put in the light of the bed. Yeah.
Like why? One of the reasons.
That's why we need to, I think.
So in Indonesia, if the water is break, but she is not fully dilated, we encourage the woman to stay in bed because to reduce the other infection or other things that might come after the water is break. So if the woman is not fully dilated, we continue to observe the woman, the labor at the bed, on the bed.
Very early, 31 centimeter. And she still has to go to the bed.
Yes.
To decrease the risk for infection for the pregnancy. Okay. That's clear, right? We can move to the next question. Any question from CDU or from Poltekkes Denpasar and Poltekkes Kartini?
Sorry. Just adding on to the water breaking or strong. In Australia, we do not restrict the women onto the bed. If the waters break, say at 1 centimeter or 2 centimeters, they're still allowed to walk around. They can just wear a pad, and we can monitor the color of the liquor by visualizing the pad. And if you're concerned about the baby at any stage, we'll be concerned by looking at the color of the liquor. Only after 18 hours of breaking the waters, the women need to get a drip and get antibiotics for infection. But
We in Indonesia, if the water breaks, but the woman not already have dilated, even one, we do that. We also do the infusion. Yeah. But if the woman already have in the labor stage, we only restrict the movement to decrease the risk for infection.
And do you also use extra monitoring on the baby, like CDG after that, or yes, but not for all women. The procedure is done only if the woman is with some risk. So for normal labor, we don't do the CPG or.
Yeah, if there is indication, we usually perform CTG or NST. But if not, we only check observe monitor the heart rate and also the pulse condition every 30 minutes. Yeah. Stress test, yes.
Okay, sorry, just to add maybe on the nostrum and why when the waters break and why we get women to walk around or move around. I think it's thinking about gravity and active, yeah, and the woman has to be active and all that helps with dilation as well.
Yeah, to decrease the because we know that when all of the water in amnion in months already come out, it will make a baby distress like that. So we restrict the movement. They or woman only can lay on the left side or the right side on the bed. Yeah.
Wouldn't the if the water is not there around the baby's head, and when the contraction comes, baby will be able to put more pressure on the cervix, and the cervix needs to be dilated more.
I think we should rethink about that, right? Because there is so much different in Australia and Indonesia about that.
Maybe that's the difference because in Indonesia, not all the women is educated also. So we have to do the some rules during the labor especially to reduce the mortality mortality rate also in Indonesia. Maybe that's the so yeah.
Okay. That's not true. Okay, we should think about that. We can discuss that next time. Okay, we can move to the next question because there is still some difference in Australia and also in Indonesia about the perspective. Any question from CDU and also from Poltekkes teams? Okay.
Do you coach the pushing for each? Do you coach the woman to push with like while she's pushing? Do you coach each woman to push, or do you allow her just to push naturally herself, or do you say okay, time to push?
One of the first one, we need to asking them now, if the strong contraction, we need to put long one. Because if there's not the strong contraction, we will get the push so hard to get the pain. It's mean she need to collect the pain until it's happy to collect for the contraction. And if the because I asking her, you feel in contraction, you need to collect that. In the very pain, you can so it's like I think it will be safe if she uses it very well. I think just get the pain, use it out for the of the baby will be the see how much. Yeah, so that's really yeah, it's like the before and the education before, don't be positive
So while you're coaching, do you have a hand on her like her uterus just really strengthen the contraction? Or are you going by which is like healthy, feeling contraction to then coach her then?
Yeah, sounds like yours. I think we feel in that impact of the contraction in the
I think that's this maybe just say purchase which she wants.
So in Indonesia, what we do is we lead when the woman is pushing. So while we directed the pushing, we put our hands in the stomach to know when is the highest contraction. Yes.
And when we fill this confirmation, we also with the contraction and the monthly contraction, filling that after contraction, yeah, we push it up. Yeah, so no contraction, we get it right.
Condition.
To continue, while we lead the contractions for the mother, because not all the mother got educated to pushing, so we lead the mother to protect the rupture of the perineum. So if the mom push so hard and not in the highest of the contraction, there can make the rupture of the perineum. So we lead the mother to protect that.
Okay, thank you. That's clear. So any question?
Thank you. I want to ask, take the case, the amniotic is free, and after 18 hours, it must give antibiotic. The antibiotic given by the midwife or collaboration about between obstetrician and midwife. And what and if happen there is any midwife clinic private in OC? Yeah. If it happen in private clinic, what will can you give the antibiotic or refer the patient to hospital? To answer.
Good question. So when the wards break, we have to consult the doctor, that's the obstetrician, and say, look, it's been 18 hours, and he just signed a piece of paper, says, yep, we want to give this antibiotic, this one, so we give 3. Yeah, and then the midwives conducted all. We have private midwives, but in the hospital and in the home. So if their membrane ruptured and they needed the antibiotics, you have to refer them to the hospital. Yeah, they can't have antibiotics at home. Yeah. So a private midwife practicing in a woman's home cannot prescribe antibiotics. They can prescribe like Poltekkes, like pain relief after birth, but not antibiotics. They're restricted in what they can and can't do. So in that situation, they go to hospital.
So I agree with Erin, and so what happens is if there is a private practicing midwife or a home birth setting, and a woman breaks a water, so at 18 hours, we will transfer the woman to the hospital for an antibiotic called benzalphenic. So she gets benefit. And benefit needs to be administered every 3 hours until the baby is born. In case of sepsis, that's when we use 3 different kinds of antibiotic. but we need the doctor to sign prescription before we can administer. So we can administer as a midwife, but we can't prescribe as a midwife, not the antibody. Yeah. Does that answer your question? Yeah.
Okay, we still have time for the discussion. Are still any question? Yeah.
So because the perfection with the perfect target. So because in Indonesia, every time we have new mother, we give antibiotic if they have stitches. Yeah, so we give antibiotic. So how about in Australia? If the mom have the home in a private home, you give the antibiotic or just painkiller?
Just painkiller. Unless there is signs of infection, we do not administer or prescribe any antibiotics for stitches. When they have a cesarean section, they get one antibiotic in theater while they're getting the cesarean section done, but no antibiotics are. So unless there is signs of infection that develop later, so we monitor it and we inform about the signs and symptoms of infection to the woman, so she can monitor herself. And if she feels like she's getting a fever, there's swelling, there's pussy discharge, or there's swellings and redness that's persistent, then she can contact us and we can do some swabs for the discharge. And if the swabs come up with infection in them, then we prescribe antibiotics. Not before that.
Okay, thank you. Is there any question?
When you deliver the placenta in Indonesia, do you roll with as it comes out?
Yeah.
Same.
Same.
Okay. Can you show them?
Yeah, in the membrane and then the living part of the placenta. There is the not the dressing and the
Yeah.
Like that's when it's
Okay, that's fair, I think. Still any question?
So guys, I want to ask you about maybe if they stay in the hospital, even this woman and the mom get the normal labor, it is led by midwife or the doctor or the option something, but still with the midwife.
If it's normal.
yeah,
Like what is
Yeah, even normal in the hospital, still with the midwife. How about in the water birth, midwife also?
Yeah, so it's usually when there's complication or there's something out of the normal limits that we advise them of. We can't let them-
so doctor will be helping if there's an indication. Yeah.
Yeah,
So normal, if the normal occurs, they in the.
yeah. We try and avoid it, actually.
Yeah.
Okay, I think that's clear. Any question?
I just want to add on to that. Adding on to that, women who have delivered normally without any complications or any risk factors, they can also get discharged home from the hospital within 4 hours, and they go back to their home with the baby. And the midwife facilitates all that discharge. We do not need consent from the doctor or the doctor to come and see the mom and the baby.
Only something like that.
Yeah, that's a different maybe, if I can add it to that. In Indonesia, the woman, in hospital, have to stay, at least, 24 hours after the labor. Yes, to observe the woman and the baby before they can go home. Yes, and also, about the normal labor, in Australia, it allowed to use the painkiller for, reducing the contraction for the mother. If the woman use that, is it, categorized as the normal labor or, with indication?
So you mean if the woman is using like gas or any pain relief medication? Yeah. So after epidural, they do have to stay back until they complete 2 trial voids. Because they didn't have sensation and we had to insert an IVC, a catheter in their bladder, so we need to make sure that they can do 2 trial voids, so they stay until that. But if they used, for example, nitrous oxide or other pain relief options but delivered normally and there were no other complications, yes, the women can still go home after 4 hours. Oh, yes, we do. Yes.
Okay, I think that's enough for this discussion session. If there is still any question for the differences of both simulation, we can have the discussion later. Okay. So because the discussion already end and the both simulation already finished, I can summarize that both simulation is great, and in Indonesia and also in Australia there is some similarity and also differences in normal labor assistance by midwife, but both of the country already do some pain management for pain relief for the women of birth. That's enough because the discussion session on the first session already finished. Based on the event rundown, the next activity is break and lunch for 30 minutes. So we can have break and lunch first, and then we can come again here at 12. Okay.
Two oceans in between us, and away for shore. There's a gate I see, and away for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding jaw. The headache of a necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and away for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding jaw. The headache of a necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and away for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding jaw. The headache of a necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and away for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding jaw. The headache of a necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and Two oceans in between us, and away for shore. There's a gate I see, there's a way for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding door. The headache pill, the necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, there's a way for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding door. The headache pill, the necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, there's a way for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding door. The headache pill, the necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and a way for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding jaw. The headache pill, the necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and a way for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding jaw. The headache pill, the necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and a way for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding jaw. The headache pill, the necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and a way for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding jaw. The headache pill, the necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and a way for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding jaw. The headache pill, the necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and a way for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding jaw. The headache pill, the necktie on my bedroom door. My conscience burning, a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and away for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding jaw. The headache of a necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and away for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding jaw. The headache of a necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and away for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding jaw. The headache of a necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and away for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding jaw. The headache of a necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and away for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding jaw. The headache of a necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and away for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding jaw. The headache of a necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do.
champion.
Two oceans in between us, and away for shore. There's a gate I see, and a way for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding door. The headache of a necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and a way for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding door. The headache of a necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and a way for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding door. The headache of a necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and a way for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding door. The headache of a necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and a way for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding door. The headache of a necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and a way for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding door. The headache of a necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and away for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding jaw. The headache of a necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and away for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding jaw. The headache of a necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and away for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding jaw. The headache of a necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and away for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal, my grinding jaw. The headache of a necktie on my bedroom door. My conscience burning, my eyes are too cuddled up with a heart condemned. I should love you, and I swear I do. Two oceans in between us, and away for shore. There's a gate I see, and away for me. Now this one sits here and whispers things to me. Now I got the devil inside. This one made a pig of me. This wall is primal. Two oceans in between us, and away for shore. There's a gate I see, and away for me. Now this one. Two oceans.
To all honorable attendees, welcome again. Now we want to start the second session in this simulation, that is solder dystocia simulation from Charles Darwin University and also from Poltekkes Denpasar and Poltekkes Kartini Bali teams. The first simulation will be present by team from Charles Darwin University. You have 30 minutes to deliver the simulation, and now time is yours. Thank you.
Do we have to like the context? Like the critical race from the board?
I'll just add it.
Yes. Yes.
Oh, so you can't show that you like, we do like we actually because the drive is really there, like watching it.
Sorry, amazing ourselves.
I've got 2 kids.
It's shown to Sandra, and I'm just going to narrate the case. So, who are you? She's aged 25 years old. She's G1, P0. Her last menstrual period was 10th of September 2023. She has been admitted to the birth suite in Prima Medical Hospital. She has been doing well during this pregnancy. All her antenatal results were normal. She had an ultrasound scan for suspected macrosomia at 38 weeks, and the estimated birth weight for her baby was 3.5 kilograms. Ibu went into spontaneous labor, which progressed quickly, and she is currently in the second stage of labor. She has been pushing for 20 minutes. Maternal and fetal observations are normal. Contractions 3 and 10 strong, lasting 60 seconds. The baby's head is now born with the next contraction, but you had to assist in the releasing the baby's chin from the perineum. After the baby's head is born, the midwives notice that the baby's face looks tight within the perineum. Ibu has another contraction, and the baby has not been born as you would normally expect, and we have Shelley as the primary midwife. On to you, Shelley.
Karen, can we have emergency present? But we have Shelley on the social, don't worry, it's Shelley. I forgot to put the call. Room 6 delivery committee, that's an emergency. Yeah. I'm just gonna have a couple people come in just to help me. Erin, what can you do, like, the turn profits? We're moving back then. Monday. Even if it's Monday. We're not flat on the floor, on the beds, and we're shuffling forward. Thank you. The profit isn't effective. Can I get some super pressure from the right side, please? Yeah. Thank you. Still not effective. I'm going to do internal exterior. Good job, team. And we grab the towel. And normal.
And we'll recommence the postnatal care and immediate care after baby's delivery as previously shown in the previous scenario. So just to summarize the scenario, what Shelley the midwife did was she was a primary midwife who recognized shoulder dystocia because the baby's head was turtling. It wasn't coming out with the contraction as we would expect it to, with the normal traction of the head. So she called for an emergency. Emergency button was pressed by Erin, and she called for an sense of emergency, which alerted all her other team members, the other midwives who were present here, and along with that, it will also alert our neonatal team, who will be present to look after the baby if need be. So Shelley brings the baby. Shelley brings Ibu to the edge of the bed, or brings Ibu's bottom to the edge of the bed, and advises Erin and Brooke to perform Beck Roberts, which is bringing the knees to the nipples for the woman to assist with the opening of the and the bed has been laying flat, which would assist the delivery of the shoulders, which was ineffective in this case. So the next step was to apply some suprapubic pressure, which was attended by Ash. She applied suprapubic pressure on the right side because the baby was lying in ROA position, so it was on the right side, hence suprapubic pressure was applied on the right, which was ineffective as well. And then Shelley went on to internal maneuvers and opted to release the posterior arm and deliver the baby by releasing the posterior arm. And Gabby, on the other hand, was scribing and documenting all of this emergency case that was happening in the background. That's big.
Thank you, CDU team, for the simulation. Now we came to the next session, the simulation from the Poltekkes, Denpasar, and Poltekkes Kartini Bali teams. You also have 30 minutes to deliver the simulation. You can prepare your simulation now. Thank you.
Now we got to the next agenda is a role play scenario for disclosure case in midwifery clinic setting. So me, the Kirana as narrator, Tiwi as a midwife Mona, Lily as assistant midwife, and Nisa as Mrs. Ayu, and Novi is the husband. So Mrs. Ayu, age 25 years old, G1, we note and note. Last menstrual period is 10th of September 2023, is in Bidan Mona Clinic and currently in the second stage of labor. And she has been pushing for about 20 minutes, and fetal heart rate has been 120 until 140 with moderate variability and no deceleration. Her contractions are regular and strong every 2 until 3 minutes lasting 60 seconds. And the baby is estimated to be 3.5 kilograms in weight. And the head of the baby delivers the fluid immediately with the baby's chin abutting the perineum. Examination general condition looks weak. Blood pressure 120 per 80 and then pulse 96 per minute. Respiration 20 per minute, fetal heart rate 125 per minute regularly. Episiotomy and infusion has been performed. The baby has been not delivered yet.
One, two, three. One minute.
The shoulder is out. The baby has been successfully delivered and she is crying, active, and her skin looks red. The baby brings on Ayu chest. The placenta is delivered. The midwife conducts an examination, checks for any sign of bleeding or uterine anatomy, and performs the suturing of the perineum. Ayu and the baby are placed under postpartum observations.
Masih.
The procedure will be considered. So the first case is clear in the midwifery private clinic settings. Now we go to the next agenda is role play scenario for Mr. case in the hospital settings.
That's all you want.
Narrator, and the doctor is Laras. The midwife still Tiwi and Lily, and Mrs. Ayu as a Mrs. Is a Ibu, and the husband is Novi, and the pediatric doctor is Nita and the assistant. So the case is Mrs. Ayu, age 25 years old, G1 Pinot Eno, last menstrual period is 10 of September 2023, has been admitted to the L&D room in Prima Medica Hospital and currently in the second stage of labor. And she has been pushing for about 20 minutes, fetal heart rate between 120 and 140 with moderate variability and no deceleration. Her contractions are regular and strong every 2 until 3 minutes, lasting 60 seconds. And the baby estimated to be 3.8 weight kilograms. And the head of the baby delivers but retracts immediately with the baby's chin above the perineum. Examination general condition looks good. Blood pressure 120 per 80. Pulse 96 per minute. Respiration 20 per minute. Fetal heart rate 135 per minute. Regularly, episiotomy and the infusion has been performed.
The baby shoulder is stuck, so we need to turn the stuff on the part to have the business. So let's get clear with this. You don't have to call by the doctor, we've got a description. And so that's something you see there right over. And now.
Baby has not delivered yet.
Okay, now I will do my something on the front, so get up this coming to the front of the page. Now, we put part in. 1, 2, 3, push. Okay. 1, 2, 3, push. Okay, stop.
The baby has not delivered yet.
Okay, now I will do the moving on the foot. So I will insert my hand here for the hand and get pressure in the shoulder. Push part again. 3, 1, 2, 3, push. Stop. Okay. 1, 2, 3, push. Okay, stop.
The baby has not delivered yet.
Okay, now I will do this one first. I will roll the baby shoulder.
The shoulder is out. The baby has been successfully delivered, but he is not crying and her skin looks pale.
Visit for at spot, busy and bright and the skin looks good.
While the pediatric team is performing baby resuscitation, the doctor proceeds to deliver the placenta.
There's no second baby.
After confirming there's no second baby, midwife Sinta injects oxytocin. After 1 minute, the baby is crying and the skin looks red. Once the placenta is delivered, the doctor conducts an examination checks for any sign of bleeding or uterine atony and performs suturing of the perineum. The baby is placed on infant warmer for observation, and the doctor explained the shoulder dystocia that just occurred, and Mrs. Ayu and the baby are placed under postpartum observation. The midwife continued to observe the vital signs of Mrs. Ayu. There's blood pressure, temperature, and heart rate.
The mom got the pregnant baby, but now your baby is on pediatric doctor to get next therapy. So now we will also keep it flowers. If you need something or you have any question, you can talk. Okay? So you now have any question?
Their general condition is good. Thank you for the great simulation from both teams. That's a very great simulation. From the simulation, we can see similarity and also differences like before in normal labor assistance. So as both team already finished the simulation, now we come to the discussion session. If anyone has have question or want to ask something to both of teams, you can raise your hand.
We just would like to know when you plan to board,
Yeah, and squeezing the form.
Adjusting it as so any adjustment that's like
To the closer to the vagina, it will help us to take to get easy to burn the placenta and to make sure that there is no blood coming from the formula. So that's why we squeezing the blood and then move the blood to closer to the vagina. Yeah, thank you, thank you. That's clear. Another question.
So my question is when you were narrating the scenario, you said that the episiotomy and the infusion has already been conducted. Is it routine to perform an episiotomy for every short gestation case?
Yeah, from Poltekkes Denpasar and Kartini Bali, who wants to answer the question? Is it routine to do the episiotomy and infusion?
Yeah, in the private clinic midwifery, we usually do for perform the infusion if there's any sign to refer to the hospital, so we can go faster. And then for the episiotomy, if we know the baby is big or we call it macrosomia, so we usually do the episiotomy. And if the mother is preemie and the baby is big, we do the episiotomy too, but not always we do episiotomy.
What is infusion? What do you mean by infusion?
Like renal catheter infusion, intravenous. Yeah. No, it's just renal catheter. It's just
Yeah, what's confusing?
no, it just prevent the mother to have loss for dehydration because of bleeding. Yeah, it's an access for the medication. If she needs to refer to the hospital and they need medication, so renal infusion help the access for them. Next question.
So I noticed with the hospital setting, that the obstetrician delivered the baby. Does the midwife at all, like, I mean, for us, we deliver the baby, like we're doing with a new consent. Now the midwives doing the delivery scan.
Sorry.
So when they were doing it like there's the clinic setting and the hospital setting and the obstetrician delivered the baby. Yeah. Do the midwives get to with the like in that situation of a shoulder
In hospital, the obstetrician that deliver the baby, midwife only as assistants. Yeah. Yeah, in hospital because there is complication, so midwife not capable to do the for complication.
Because that emergency cases, so we can use that. The only thing is people.
So yeah, in Australia we use it. I just got a question. I'll get it on the phone. No, ask me.
Sorry, one more question. So you were applying under pressure. So we don't do that in things like, we don't have under pressure law, right? Like I've never seen that. Is that like, obviously it's set standard here. Like, you know, one of the shop just ask them. And it's never.
Sorry, your question is, are all the labor in hospital done by the obstetrician? Is that right? No?
That was my question. Yeah. I had two questions. My first one was, do the obstetricians deliver in the hospital setting? Because like, as a midwife in Australia, we will perform the maneuvers, not the obstetricians in a hospital setting. Then I also asked about the blood pressure as well. Yeah.
So, yes, so we do that. We do that to help to narrowing the shoulder, so it can deliver easily the shoulder.
Oh, that was just super moving question.
Yes,
Let one go.
So the pressure is on the superpelvic. Yes.
Let's clear around. Okay, next question. Any question? Yeah. I noticed that you didn't lay the woman down after diagnosing shoulder dystocia and then doing. So do you do the McRoberts maneuver with shoulder dystocia? Do you lay them down?
It's because our books from our lecturer, it say that the megabyte number is defaulted.
In Australia, one position that used when maneuver McRobert.
If we do semipolar, the diameter of the pelvic is bigger than it lay down.
So make the press more harder when in the semipolar position of sitting position. The leg is open.
Yeah, so it's really linked right back.
Yeah, leg is open. And then
Legs moving at the back.
In Australia, the position is like that. I think that that has the same aim to make more pressure. Yeah, more room from the legs. Yeah. I think there's just a different position. Yeah. Okay. The next question. Any question? Yeah.
Is it routine to continue pushing if shoulder dysplasia are detected, or do you advise the woman to stop pushing?
Wants to answer the question?
We also tell her to stop pushing when we stop do the maneuver. Like if we are not doing the maneuver, we stop the moment pushing. But when we are doing the maneuver, we tell her to push.
We advise to stop pushing. Instantly that if a woman is pushing, it is going to aggravate the bone-to-bone issue. It is going to aggravate the issue. So we advise not to push. They will flat and do the maneuvers and with the axial pressure, instead of downward punch. But the second question comes to that we saw that you use downward traction. Like that, it's what the axial. So
So there is differences again about pushing in Indonesia and Australia. In Indonesia, we still encourage women to pushing when we're doing the maneuver, and in Australia, midwife choose patient to not pushing when doing the maneuver like that.
We're just discussing with each because I think, it's like, what do we mean when we say axial pressure and downward pressure? I think that's what we're discussing about, and we're just wondering whether. Because I think what they're trying to say is, when you are, if there's a shoulder dystocia and you think about it, that the shoulder is stuck underneath the symphysis pubis, if you push hard before, then you might make that worse. And that's why, again, because it's a bone-to-bone issue. So really you're thinking about that if you
that's actually the game and the arms. Things for that's
About breathing, we still have to learn more about the shoulder dystocia, because here in Indonesia, we as midwife usually only done the maneuver macrobat and also masanti, never done the wounds maneuver, and there's obstetrician that do that. So maybe we still learn more about that. Yeah. We never doing that in private library. Yeah.
Just a quick question, because I think maybe you might have answered it, because you said you only do macrobials and suprapubic pressure. Do you do internal maneuvers as well? Okay. Okay. In Australia, if the midwife is competent, even if when you call the doctors come in and they see that the midwife is doing the right thing, they might just send and allow them to. So it depends on the competence and whether the midwife is experienced to do it.
Actually, in emergency cases, we still have know how to do the medical right.
I've got another question. The question just way down my head. Yes. How many? So if it was in a private practice, and you're not allowed to do internal maneuvers as a midwife, how long would it take to transfer a woman to the hospital? And what is considered the ideal time frame to deliver the baby from detecting to registration here?
Yeah, to answer that, actually every region has different time because it's depend on the hospital near to the private clinic. So yeah, it's varies. So that's why in this occasion, in this scenario, we are as a midwife has to prevent this to happen in midwife clinic. So we have to do really good examination whether the baby about the weight of the baby. So this case is not happened in the midwife private clinic. And so if the worst scenario happen, for example, we already do the microbes and Masanti and it's not working, so we immediately call the doctor and we roll the machine.
In Australia, maybe consider delivery of the baby from detection of children's dysphagia in 7 minutes maximum. I feel is 4 minutes from detection for the best outcome for baby.
Initially, we get cases like that, yeah, because in private midwife clinic, we do the identification first. We have early detection first. So if we already identified that the woman will get birth with macrothomia babies, we already refer them before they get the second stage labor. So even if there is shoulder dystocia, we usually have to finish in make position only. So it's very rare for us to have the Masanti and then how long we have to refer to the hospital. We can imagine that. Yeah. Yeah, yeah. So I think the most important in private midwife clinic is identification and also early detection for the macrosomia babies. Yeah. Maybe I think that's clear enough for the question. If anyone still have any question, you can raise your hand.
Okay, I want to ask that your simulation is very fast, and I have a clear vision to it. And do you perform an efficiently for that case for showing difficulty?
From CDU team, who wants to answer the question?
If we need to, not always, if you're having problems, sorry, using me.
Yeah.
If you have to perform internal maneuvers, for example, and there is no space, it's very tight for us to set up because only people set otherwise it's not recommended.
Okay, that's true. Any question? Other question?
Medication in Australia. Oh, I said, find out. You'll find out. Yeah. They don't think kids, you know. Oh, yeah, that's a good share.
No question, please? Okay. No one have another question about shoulder dystocia simulation from both for both teams? No, I think the simulation and also the discussion is clear enough, right? Yeah. Because the discussion session already ended and we have already sharing so much about the differences and similarity in Australia and also Indonesia about normal labor and also shoulder dystocia. I can summarize that all of the steps that we use for assistance in share more about that. Okay, because the discussion ended finally finished. Now I will conclude this simulation for today. I hope all of you enjoy this program and thank you for your participation. Stay safe and healthy. I will give the time back for the Master of Ceremony. Thank you, and
Thank you to Mrs. Deputy Gita Arnei STRK as moderator who has guided the practical simulation activity very well. The event continue with the presentation of certificate to our moderator and facilitator from Poltekkes Kemenkes Denpasar for today's simulation activity. The representative of Charles Darwin University is welcome to hand over the certificate to the moderator and facilitator, namely Mrs. Niputu Gita Arnei STRK as a moderator, Mrs. Nikomang Eni Asiti SKMM Cup as a facilitator, and Mrs. Desa Dr. Ayu Ardani SSC as a facilitator. The event continue with the presentation of certificate to students from Poltekkes Kemenkes Denpasar for today's simulation activity. The representative of Charles Darwin University is welcome to hand over the certificate to Komang Okdina Okta Trijayanti, Amalia Sabila, Nima Denita Dwiyandari, Niputu Dian Widyasturi, Ida Ayu Prajna Kirana Yoga, Gusti Ayu Anissa Kumala Sinta, Kadek Metriana Pratiwi, Kadek Lara Suyanti Putri.
Thank you, Mrs. Thank you so much.
To our facilitator from Poltekkes Kemenkes Denpasar and from Poltekkes Kartini Bali. To Mrs. Nikomang Eni Astiti SKFM Cup, Bidan Maria Gabriela Yuniati SST M Cup, and Bidan Niwaya Noviani SST M Cup. Let's continue with a presentation of certificate to student Poltekkes Kartini Bali for today's simulation activity. The representative for Charles Darwin University is welcome to hand over the certificate to Emiliana Febrianti, Juwita Angrelina Mungu, Monica Ramudaiko, Maria Goretti Adetalo, Novian Devita Dianape, Nilo Sri Utami Kumudani, Nimade Ade Devika, Putu Seni Lisya Damayanti as a student. Next, there will be a joint documentation session to student and lecturer from Poltekkes Denpasar, Poltekkes Kartini Bali, and students from Charles Darwin University are invited to come forward. To the official are welcome.
Ada kursinya di depan ya. Gitu ya. Joko.
Okay. One, when I said midwife free, says save the mommy and save the baby. 1, 2, 3. Midwife free, save the mommy, save the baby. Yeah. series of LED simulation activity for today. Hopefully, what we get from Charles Darwin University simulation LED activities, the Poltekkes Denpasar and Poltekkes Kartini Bali regarding normal childbirth and shoulder dystocia can be of benefit to all of us. I would like to thank you, the invite guests and participants in the LED simulation activity who participate in this activity start to finish. I am Putri Citra as the Master of Ceremony. Representing all the committees on duty, would like to thank you for your participation and support. And we apologize if there is something you don't like. Finally, I close with Parama Santi. Om Santi 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 Om. Wassalamualaikum warahmatullahi wabarakatuh. Salam Nama Budaya. Peace be upon us all. Thank you and see you at the next activity.
Two oceans in between us, and away for shore.